So it looks like we're about to start. We have all of our speakers and panelists here. For everyone who is in the attendees list, welcome to today's webinar. I'm Nicole Santero. I'm the Director of Communications for the UNLV School of Public Health. Just an FYI on how the format's going to go, we have a couple presenters as well as panelists who are going to share some presentations with you. Before we go on to our moderator, just an FYI to everyone that we are taking questions. So if you look at the bottom of your screen, there will be a Q&A box. So if you do have questions, please put it in there and we'll take those at the end. Don't leave them in the chat because we might not see them, so please use the Q&A box. So in the meantime, I'd like to introduce our moderator for today, who will give you an introduction and brief overview of what we're going to be doing. So.
Good afternoon, everybody. Thank you for making time to join us for this important webinar. My name is Jose Melendres, and I am the Executive Director in the Office of Community Partnerships for the UNLV School of Public Health. And also I currently serve as Chair for the Nevada Minority Health and Equity Coalition. The title of this webinar this afternoon is Amplifying Equity, the COVID-19 Impact on Diversity and Equity Communities, Populations in Nevada. Again, this is the first webinar in a series of webinars/videos that will be pulling together from key speakers and experts in the field of public health to address these issues as they impact diversity and equity populations. It's part of the coalition's work to continue to advocate and support our diverse populations and equity populations in Nevada as we work not only in the state of Nevada, but then across the field with different experts across the United States and in this area. So for today, I'd like to thank our sponsors and co-hosts who are working with us. Again, the UNLV School of Public Health. Thank you to Dean Sean Gerstenberger for his continued support and working with our coalition and our communities in this time of the COVID-19. Again, the Nevada Minority Health and Equity Coalition, Tina Dorch and the Nevada Office of Minority Health and Equity, the Nevada Commission on Minority Affairs, Dr. Melva Thompson-Robinson with the Center for Health Disparities and Research, and Ms. Gina Glass with the Dreamsicle Kids Foundation. Thank you to all of them for being on board and working with us today on this webinar. As we have learned, the COVID-19 has brought to the forefront the great inequity that exists in public health. It has shone a light on the impact of those of diverse backgrounds and equity populations who are not getting the same access to resources or are being impacted even more so as we continue to see the growing numbers of those who are falling sick, being ill, those who are on the front lines and maybe not having all the right equipment that they need to do their work. So for this first session, we pulled together a team of experts in different areas to look at the different communities and populations that we're going to be working with. Our speakers include, and I'm going to do an introduction right now of all of the speakers, minus one who Ms. Sheila James will introduce, and then we'll get started with the panelists. So first I'd like to thank and acknowledge Ms. Sheila James. She's a public health advisor with the Office of the Assistant Secretary for Health, the Region 9 Office for Regional Health Administrator. She has been, I cannot say enough about Sheila. She has been a resource, a mentor, supporter of everything that the coalition has done, the work that we've been trying to do in I think we're now in our 6th year. She's been nothing but supportive and guided us in every step of the way and has been there for everything that we do and ask her to do, participating in our meetings, and just everything that we need, and a phenomenal individual. We are lucky to have her on board with us. She'll be introducing our keynote speaker in a bit. She was recently promoted to the position of Regional Minority Health Analyst in April. And again, she is just goes above and beyond the call of duty for her work. And just something that I want to share real quick, she has been instrumental in driving this work in terms of the impact on a regional level to addressing the needs of diversity and equity populations. So thank you, Sheila, for your work and for your continued support. Followed by, then we will have presentations from Dr. Francisco Sia on the Asian Pacific Islander community. Currently, Dr. C is professor and chair in the Department of Environmental and Occupational Health at the University of Las Vegas School of Public Health. Dr. C, prior to joining UNLV, worked at the National Institutes of Health, NIH, as a senior extramural program director for 12 years. He worked at the Centers for Disease Control and Prevention, CDC, as a senior health scientist for 4 years. In 2003, he led the CDC SARS community outreach team in Asian communities in the US to mitigate the fear and stigma associated with SARS. Also joining us today, Dr. Erica Marquez is an assistant professor for the School of Public Health. Her research focuses on health disparities with an emphasis on the built environment and system-level influences that result in equities in health. She has devoted the last decade of her career to working on local issues focused on housing quality, housing-related health concerns, and housing equity. Dr. Marquez, like many of our speakers, is both passionate about using data and research to inform programs, policies, and practices as we advance the field of public health. Our next speaker will be joining us, Dr. Crystal Lee. Dr. Lee was born and raised on the Navajo Nation in Arizona. Her tribal clans are, excuse me if I mispronounce this, Taichi Ni, Red Running Into the Water, Tabaja, Water's Edge, and Shenjinkini, Cliff Dwellers, and Kin El Ichni, Red House. Her educational journey had led her to complete her undergraduate studies at Arizona State University and her graduate studies at the University of Nevada, Las Vegas. She's completed her predoctoral training focused on indigenous health from Johns Hopkins University and her postdoctoral training at UCLA School of Medicine focused on infectious diseases, preventive medicine. Dr. Lee is everywhere, and I'm always just so amazed at her work and everywhere that she's involved with on behalf of our Native American population and as well as diversity and equity groups. The next speaker, I'm proud to recognize Dr. Melva Thompson Robinson, who's been a mentor, an advisor, and just an advocate in diversity and equity populations for years. She is currently a professor in social and behavioral health and the executive director of the Center for Health Disparities Research in the UNLV School of Public Health. She was the project director for the Southern Nevada Teen Pregnancy Prevention Project, which implements an evidence-based intervention with African-American youth ages 14 to 19 in African-American faith-based organizations. Among many things, Dr. Thompson Robinson was also a member of the U.S. Department of Health and Human Services Region 9 Regional Health Equity Council. And our final panelist for today is Dr. Lauren Chappell-Love, earned her master's in forensic psychology at the Chicago School of Professional Psychology. She went on to earn her PhD in counseling psychology from the University of North Dakota. Her clinical experience primarily lies in forensic and correctional psychology. While in the community, she has worked with court-mandated individuals in sexual health. Dr. Chappell-Love is focused on diverse populations, LGBTQAI, and people of color, etc., and the ways that they process and can excel while living within systems of oppression and majority cultural spaces. So again, I want to thank all of our panelists today. And with that, I'm going to be turning it over to Ms. Sheila James, who will introduce our keynote speaker. Take it away, Sheila.
Thank you, Jose. Good afternoon, everyone. It has been a pleasure to partner with the Nevada Minority Health and Equity Coalition, UNLV School of Public Health, Nevada Office of Minority Health and Equity, Nevada Commission on Minority Affairs, UNLV Center for Health Disparities Research, and Dreamsicle Kids Foundation to plan and present the first in a series of webinars that will examine the disproportionate impacts of COVID-19 on diversity and equity populations in Nevada. The Office of the Assistant Secretary for Health, Region 9, is located in San Francisco, California. We are a small but mighty team of 3 led by our Regional Health Administrator, Commander Matthew Johns. As the senior federal public health official and scientist in the region, the Regional Health Administrator performs essential functions for the Department of Health and Human Services in 3 major areas: prevention, preparedness, and agency-wide coordination. These functions directly and indirectly support the work of HHS and individual federal agencies within the department. Region 9 encompasses Arizona, California, Hawaii, Nevada, American Samoa, Commonwealth of the Northern Mariana Islands, Guam, Federated States of Micronesia, Republic of the Marshall Islands, Palau, and 150 federally recognized tribes. It is important to pause here and note that while African Americans, Asian Americans, Latinos, and Pacific Islanders are disproportionately impacted by COVID-19 throughout Region 9 and across the US, in Region 9, per capita, COVID-19 has taken the greatest toll in Navajo Nation, which as of today has 7,045 positive cases and 335 deaths. In addition to supporting the activities and initiatives of the Regional Health Administrator, serving as Regional Minority Health Analyst, I support the initiatives of the HHS Office of Minority Health. Under the leadership of Deputy Assistant Secretary for Minority Health, Rear Admiral Felicia Collins, the Office of Minority Health is one of 8 offices of minority health within the department. The HHS Office of Minority Health leads and coordinates activities that improve the health of racial and ethnic minority populations and reduce health disparities. One such effort of the Office of Minority Health is the release of the new Health Disparities widget, which provides an easy way to find health disparities data related to the Healthy People 2020 objectives for the leading health indicators. The leading health indicators are high priority health issues that serve as measures of the nation's health that, when addressed, will help reduce the leading causes of death and preventable illnesses. The widget can be used to browse data by disparity type and leading health indicator, and provides charts and graphs of disparities data at your fingertips. Simply embed the widget on your website to provide your stakeholders easy access to the latest available disparities data. Once you've added the widget, there's no technical maintenance required. The content will automatically update with the latest available data. We'll place a link to the Health Disparities widget in the chat box. We encourage you to explore, use, and share the widget to help inform issues related to reducing health disparities. It is now my distinct pleasure and honor to introduce Dr. Sergio Aguilar Gaxiola. Dr. Aguilar Gaxiola, MD, PhD, is Professor of Clinical Internal Medicine in the School of Medicine at the University of California, Davis. He is the founding director of the Center for Reducing Health Disparities at UC Davis Health and the director of the Community Engagement Program of the UCD Clinical Translational Science Center. Dr. Aguilar Gaxiola's research includes cross-national comparative epidemiologic research on patterns and correlates of chronic health conditions, mental health conditions, and substance abuse disorders in general population samples. He is currently leading efforts in a 5-year community-initiated and outcome-driven project aimed at improving access and utilization of mental health services in historically underserved populations in Solano County, California, and promoting interagency and community collaboration through innovation at the county level. He serves as co-chair of the steering committee of the National Academy of Medicine, Assessing Meaningful Community Engagement in Health and Healthcare, a project of the Academy's Leadership Consortium and the Robert Wood Johnson Foundation. Dr. Aguilar Gaxiola is the author of over 180 scientific publications and the lead editor of the book, Depression in Latinos, Assessment, Treatment, and Prevention, and co-editor of the book, Mental Health Epidemiology in Latin America and the Caribbean. He has received numerous awards and recognition for his work to reduce health disparities and achieve health equity. Dr. Aguilar Gaxiola.
Yes, thank you so much, Sheila, for the very, very kind introduction. And thank you for all the organizers, Jose, Nicole, Tina, all of the organizers for allowing me to be a part of this wonderful seminar series. I'm honored for that and looking forward to the 3 webinars that are scheduled. Can you see my slides?
We can see it.
Okay. Well, thank you once again. Just to, what I'm going to be speaking today is to bring attention to the disparities in COVID-19 cases and deaths by race and ethnicity, and something that has been more invisible, which is by age groups. And I'll touch a little bit also on the mental health impact of COVID-19. I'm going to start with this remarkable diagram put together by the World Economic Forum, which is an independent international organization and nonpartisan. And what you see there is a very elaborate hub with spikes and connecting so many elements, which is what COVID-19, the pandemic, has been impacting. And I'm going to read this quote from a recent report from the World Economic Forum. And it says COVID-19 threatens to become one of the most difficult tests faced by humanity in modern history. As the pandemic has spread, it has taken lives, stirred anxiety and political drama, overwhelmed health systems, and triggered potentially lasting geopolitical change. And indeed, it has taken lives. And just want to emphasize and share with you this article published by 3 notable colleagues, Dr. Owen, Carmona, and Pomeroy, which they early, as things were unfolding, that they brought attention to what they call failing another national stress test on health disparities. That was back in the middle of April, and this is what they were pointing out. And they were emphasizing the disparities that at that time we were already experiencing. In New York, Hispanic and Black people accounted for 34% and 28% respectively of deaths from COVID-19, even though they represent only 20 and 22% of the population, while white people accounted for 27% of deaths, even though they represent 32% of the population. So they capture in a snapshot in how things have developed. And this is a very dynamic process in which as time goes and as we learn more about how this is playing out, especially for communities of color, we observe even more pronounced disparities both in cases and in death. This just to share another snapshot. These are the percentages of Blacks, Latinos, and people of color by some states and in terms of cases and deaths. And what I want to call to your attention is tremendous disparities if you take a look at the gray bar, which are the deaths, COVID-19 deaths, in relationship to the blue bar, which is the state population. So you see that in Latinos, in many instances in different states, in Blacks as well. In the case of Louisiana, at that time, there was a tremendous disparity between the distribution of African Americans in the state of Louisiana and the number of deaths. Here in Nevada, this is data from this weekend on Saturday. This is the distribution that I saw of now, as of today, there are almost 14,000 cases and almost 500 deaths in Nevada. But what I want to bring to your attention are the disparities between the percentage of African Americans in Nevada and then the percentage of deaths. You see a disparity there. There is a disparity also in that snapshot of Asians, and disparities also in Hispanics, except that we don't see the disparity in the number of deaths, but we are seeing it in the percentage of cases. And I would say not yet, because once again, this is a very dynamic picture of what is emerging. Certainly, we have been seeing that in California. For example, this is in California, and what you see there is what's happening with Latinos. You know, Latinos ages 18 and older, they represent about 36.3% of the population, whereas the number of deaths is 40.6, and the number of cases is even more pronounced. What I'm not showing you here, but you know, I wish to have enough time to show you, is when we break down by ages, because that's a very, very telling story. And I'm going to emphasize that with the next slides. This is what is happening also with African Americans. You know, a tremendous disparity in terms of the number of deaths in relationship to the percent in the population. And that this is not only happening to Latinos and African Americans. This is extending to other communities of color. In this case, American Indian and Alaska Natives in some states. The most notable that I want to bring to your attention is what is happening in New Mexico, in which you have that the percent of the total population of these two population groups is 9%, and yet the percent of deaths is an amazing 47%. Sheila already mentioned the tragedy that is happening in the Navajo Nation. It has been, you know, documented that among one of the more pronounced number of cases per population and also number of deaths. And just want to emphasize this, that the Navajo Nation, among other tribes, is facing some of the worst rates of COVID-19 in the United States. Long-standing health inequities due to persistent feral neglect, a high prevalence of chronic disease, and geographically dispersed multi-generational homesteads, often with no running water or internet access. There is this, you know, and by the way, I'm presenting you articles that are more recent than the previous one that I have presented to you, except the rates, but I took them this past Saturday. This is a racial breakdown of cases, and this article was published at the beginning of June. And what it says is, unsurprisingly, minority groups in most states are experiencing higher rates of COVID-19, and this is due to a number of reasons. These groups are more likely to have jobs and don't allow them to stay home and socially distant. Many of our populations that we're describing have been called essential workers, and they don't have this luxury to stay home and work remotely. They have to risk their lives to work in jobs that puts them at high risk of contagion. And also they come back home, often in small quarters. So in addition to that, these communities experience health disparities that lead to higher rates of diseases, such as diabetes, heart disease, COPD. In fact, let me share with you, this is, adults ages 18 to 64, which are at higher risk of serious illness infected with coronavirus by race and ethnicity. And why I want to emphasize the percentages, these inequities in the disproportions of, for example, American Indian or Alaskan natives, Blacks, Native Hawaiian and other Pacific Islanders, and Hispanic that tend to have, along with white as well, to tend to have higher risks of serious illness, and this compounds the problem and puts them at risk of deaths. I want to bring to your attention, this comes from the Substance Abuse and Mental Health Administration, and they spoke about this double jeopardy, that on the one hand, there is this COVID-19 and also the behavioral health disparities for Black and Latinos, and I'll present to you, share with you some data related to that. But this provides a summary of a summary of what I had mentioned to you so far. So people of color are at an increased risk for serious illness if they contract COVID-19 due to higher rates of underlying health conditions such as diabetes, asthma, hypertension, and other health conditions. More likely to be uninsured and to lack a usual source of care, more likely to work in the service industry such as restaurants, retail, and hospitality that are particularly at risk for loss of income during the pandemic. Also, more likely to live in housing situations such as a multi-generational families or low income, and housing that make it difficult to social distance or self-isolate, and finally, often working in jobs that are not amenable to teleworking and use public transportation that put them at risk for exposure to COVID-19. I think that this pretty much summarizes in poignant ways what is happening with our communities of color. This is a more recent article that emphasizes, this another aspect that I would like to put it, in your minds, and that is what is happening with not only in the inequities by race and ethnicity, but also by ages. For example, we know that the coronavirus is killing Black and Latino adults in the mid-30s to mid-50s, at least 6 to 10 times higher than whites. This is a recent report from the Brookings Institute. And look at that steep bars on the increase. What you see there is that there is an increase in Black and Hispanics, the orange and gray bars. And every single, especially the 50 to 64 age groups. This is related to how this is playing out by age. But for example, in California, what it is not clearly described here is that the disproportion of young Blacks and Latinos, from starting from 18 to, let's say 34, and then 35 to 49, etc., is notable, which means that there are young breadwinners that have to go out and work in order to maintain the family with an increased likelihood of being fatal for them and their families. And you just think about the possible implications for the mental health of those outcomes. This is a paper that came recently from the Harvard Center for Population and Development Studies. And what they are emphasizing is that COVID-19 mortality rate ratios are 7 to 9-fold higher for Blacks, Hispanics, and American Indians, Alaska Natives compared to whites. And these are extreme and reflect the devastating toll that COVID-19 has taken among communities of color. And I decided to include this paper and this quote because they really call to the attention of all of us that the statistics that we get from different states, that age-specific mortality rates for COVID-19 should be available as well as by gender, in addition to race and ethnicity. Now I'm going to share, I'm going to change gears a little bit and speak a little bit about another pandemic, excuse me, that is emerging. And that is the mental health crisis that we are experiencing increasingly, I must say. This approaching wave of mental injuries will be met in coming months by a severely broken system. This is a very important article that came at the Washington Post that really brought attention at the national level about this, about the mental health crisis. Shortly after, Time Magazine came up with this article on the psychological toll, the mental distress that Americans nationwide had been experiencing, and showing things like this. The quote is roughly 70% of Americans experience moderate to severe mental distress, and that is triple the rate seen in 2018. And then Dr. McGinty from San Diego State University, the author, was quoted to say that in some ways, this is a perfect storm for mental health issues. We are dealing with social isolation, anxiety around health, and economic problems. All of these are situations linked to mental health challenges, and these are hitting many of us all at once. I don't know about you, but I can tell you that I certainly feel it. You know, I feel much more distress. I feel, you know, the anxiety in people around me. And I think that this is playing out very, very widely. At this time, the paper has not been published, but a month later, it was published on the Journal of the American Medical Association. And what I want to bring to your attention there is that tremendous disparities between what was happening in 2018 versus 2020. And in some cases, it was double and even triple, like in the case of Hispanics, as you see on the screen. Something that I'm not showing here is by age groups. And what is an eye-opener is that the younger age group, you know, that goes up to 17 are the ones reporting the higher rates of psychological distress and loneliness than any other age group. Something that I wanted also to share with you is a more recent article of this time series that has been followed up week after week of people that people that screen positive for both anxiety and or depression. And what is you can see there that these are weeks after week with Latinos up until May 21st that were over 40% were experiencing anxiety and depression. A little below that, Blacks, and then below white and Asians. But the point that I want to make is that what happened during the week in which, right after the week in which the video of George Floyd's killing began to spread, this is the steep increase that we saw on the Black community and also the Asian community. And interestingly, with Latinos, it came down, and in case of whites, it kind of maintained the same. Would be fascinating to discuss with you, what might be related to that. And I'm sorry that we won't have enough time. But this is just to emphasize that in addition to the pandemic and the stress and the very negative consequences that it has created, there are other events that we have experienced nationwide, like the killings of members of the Black community. This is just very quickly, this is part of the double jeopardy that that SAMHSA presented in this report. This is how the tremendous treatment gaps, and treatment gap is defined of those who suffer from any mental illness or substance abuse. What is the percentage of that is receiving services or treatment? And what I want to bring to your attention, and this is an eye-opener, certainly, and this is before COVID-19, by the way, that approximately 93% of Hispanics or Latinos with co-occurring any mental illness and substance use disorders, 93% didn't have a treatment. I venture to say, even though I haven't seen data, that this problem has been even more pronounced now. This is with African Americans, which is about the same kind of ballpark. This is with the co-occurring disorders, 91% have not received treatment. And in the case of substance use, is basically 89%. This is, these are incredible disparities. This is my last slide. I don't want to leave you with just this very, very sobering, picture of what we are seeing, of a picture that is dynamic. This is unraveling, but I want to leave you with what I think that defines our communities, and that is resiliency. And by resiliency, there is this definition: an individual's human ability to persevere in the face of adversity and demonstrate a capacity to overcome and self-regulate to deal with past, present, and future traumas and challenges. And what I want to emphasize is that our communities are very resilient. They have protective factors that I wish that we would have enough time to talk about it. And maybe in the discussion, we will. So I'm finishing here, but I want to emphasize that the data that I presented to you, and things will continue to change as we move, that this is a clear, from my perspective, a call to action. and that is important that every state is able to present data by race and ethnicity and by age groups, and that definitely more resources need to be invested in order to address these tremendous disparities. With this, I'm get this back to Nicole or the next speaker. Thank you.
Thank you, Sergio, for a great presentation. That's phenomenal information. And yes, these slides will be made, these presentations made today will be made available on our website for everyone. So next is we're going to be going to Tina Dortch. She'll be presenting as we dive into the Nevada information. Tina will present us with some of that information. Thank you, Tina.
Thank you very much, Jose. Can everyone hear me?
Yes.
Thank you. The collaborative efforts of the entities sponsoring this web series is an indicator of how significant this moment in time truly is. Our commitment is to search our respective networks, to bring expertise specific to socially and or medically vulnerable populations to one educational platform. This series will include an update on Nevada's COVID statistics and related efforts to improve participation in and the collection of data. This update, provided by my office, will be a reoccurring feature of the series. Nicole, if you can go ahead and start by pulling up the first dashboard that talks about the state's total population. First of all, just to give you a bit of backstory about our sources of information that I'll be referring to. This is the state of Nevada's COVID dashboard. A link can be found in my webpage, but the item is actually managed by the Department of Health and Human Services Office of Analytics. The data is updated on a daily basis, it's 7 days a week, and it's usually available after 9 a.m. And for today's presentation, I'm using data as of yesterday, June 22nd. And this first slide that you're taking a look at is not news to those on this phone call. Our population of about 3.149 million is really trending to become a minority majority state. And Nicole, if you can go to the next graphic that demonstrates total people tested. Our COVID dashboard as of yesterday shows that 243,574 tests were performed as of yesterday. And just 1 week ago, we were at 216,464 tests performed. Well, that's a 27,110 additional tests since June 15th. So just to give you a bit of context about how these numbers come to be, the state relies on a series of laboratories around the state. And as of yesterday, the University Medical Center and the Nevada State Public Health Lab, they were collecting the most tests with a total combined of about 58,000. Now, most of you are probably aware, if you watch the news, that there's an increase in testing and that individuals believe that this is the subject of some debate. And to that point, how many cases are there here in the state of Nevada? Nicole, if you can go to the slide that illustrates, as of yesterday, we're at 13,535 slides. And what I'd like to share with you and point out is that during the last week, one constant has been the largest percentage of cases being reported, and that's coming from individuals identifying as Hispanic. Back on June 15th, that number was 32%, but as of yesterday, we're looking at 44%. And I believe that we heard about that from the last presenter. But taking us back to that conversation around testing versus case growth, some officials believe that increased testing is the reason we have seen case growth. And we've seen it in Nevada, for example, go from 11,279 1 week ago to, again, 13,535. Well, sure, we can actually see that the case growth is trending upwards. However, it's important to note that the nation is very much within the first wave of this virus. The spikes are not associated with a second surge. Think of waves recessing away from the beach. Nevada, the sand is not dry just yet. We're still standing in puddles. What we're doing now is dealing with a chain of smaller waves or the spikes that we've been witnessing. Now, more testing does in fact turn out more cases. However, there's two things to keep in mind. One, if widespread testing was the entire reason for the rise in cases, you'd expect to see the proportion of positive tests go down, or at the very least remain steady, but we're not seeing that. This then indicates that there's new infections being reported. And then item number two, remember that deaths tend to lag behind cases. This brings me to the last slide from the COVID dashboard, and that is that the death rate here in the state. Nicole, if you can please put that on the screen. We're currently looking at 489 souls that have been lost to this disease. And a trend to monitor when we think about that is that Nevada involves Asian and Black populations succumbing to COVID at rates greater than they appear in the general population. If you think back to that one slide about the population by race here, 10% of the state's population identifies as Asian, but yesterday, 15% of the deaths were from within that category. Likewise, 9% of the state identifies as Black, but 13% as of yesterday were Black Americans who lost their lives to COVID. Now, what I'm here to talk about is data, and to address these type of disparities really does require reliable data. The nature of racially stratified COVID-19 data throughout the country, and including Nevada, it's imperfect. I'm going to share two examples. One is about that nebulous other category. Of the dashboard's racially stratified indicators, the total number tested data point is very concerning. As of yesterday, 18% of test takers' racial ethnicity was defined as other. Now, how do we explain this? Having a double-digit other category could have a significant impact on our ability to accurately monitor disease incident and trends, initiating epidemiological case investigations where appropriate, or the performance of accurate contact tracing. So Nevada's COVID-19 dashboard's racial and ethnic data, how do we come about this? It is oftentimes acquired via a combination of things like lab data and case investigation data, and also the matching of other Department of Health and Human Services programs. So most of the sources that I just mentioned make racially identified information imperfect and does not replace self-identification. If you could now pull up what we refer to as our Behavioral Risk Factor Surveillance System Report. Again, sharing you just other data sources that we at the state work with, and me in particular. This particular report is the largest representation of public health data in the world, and is compiled using phone surveys. The one before you was conducted in 2017. On this survey for 2017, it involved about 400,000 adults. About 3,700 came from Nevada. And I want to share this with you to support a conversation, again, from our previous speaker about comorbidities. We know that comorbidities put minorities at a higher risk for viral transmissibility, disease severity, and even death. So taking the diabetes example into account, this report shows that of the 3,724 Nevada participants in this report, Black persons accounted for the largest group with a prevalence of 16.7%. Black people, remember, account for 13% of COVID deaths. So this takes me to that second opportunity we have to refine how we report on our data. Currently, the COVID-19 dashboard here at the state does not reflect what our previous speaker referred to as the double jeopardy effect, which is how we know how many of those Black persons who succumbed to COVID also had diabetes. This will definitely be information that we need to identify. But improvements are happening. And on the federal level, the US Department of Health and Human Services recently issued a mandate that impacts laboratories. Remember, that's a large source for our COVID data. And that announcement mandated states that race, ethnicity, age, and sex is now required for labs to report along with their test results. The guidance standards reporting to ensure public health officials have access to comprehensive and nearly real-time data to inform decision-making in their response to COVID-19. And then here on the state level, offices of minority health and equity around the country, we're all committed to better data collection because we know that having equitable access to testing and accurately determining the burden of infection on vulnerable groups often comes down to how reliable that data is. Now, my office in particular, as this state's Office of Minority Health and Equity, lots of things are going on, but specifically, I want you to know that we and I, working with this collaborative, this organization, these groups who are sponsoring this event, we're going to be educating diverse communities that self-advocacy involves greater participation in data collection activities such as surveys and listening sessions, contact tracing, and even the upcoming census. During today's congressional hearings before the House Oversight Committee on Energy and Commerce, we heard from leaders of the CDC and the FDA, and of course our favorite Dr. Fauci, and also my hometown DHHS, the Health and Human Services Division. We heard of the negative effects caused by our access to information issues. So as a state, Nevada must be ready to reliably support the national data infrastructure. And lastly, if you could please pull up for our viewing pleasure, a research flyer. This is this morning's congressional hearing manifested. They also talked about the importance of vaccine confidence. And for this reason, I present to you a real-time opportunity. This is a COVID-19 research study. The study involves the collection of blood samples from people who tested positive for COVID-19 from mid-May on. The study represents an opportunity to ensure resulting COVID vaccinations reflect all biogenetic considerations. This is largely due to the principal researcher on this study. Her name is Dr. Atoya Adams. She is a Black female clinician chosen as one of the only 2 sites in the United States to conduct this ground study. And it will lead to the creation of a vaccine, hopefully. And we would love to be a part of that and make sure that we have our representation counted. She respects the reservations that many people of color hold about getting involved in trials, no matter how invasive. But I urge you, it's worth a conversation to have with her to learn whether or not you can be a part of this solution to COVID-19. This concludes my remarks. Back to you, Jose.
Thank you, Tina, for that information. And again, everybody who's on the webinar, we will be posting this information to our website, School of Public Health and Nevada Minority Health and Equity Coalition. So now beginning with our panelists. First, we have Dr. Francisco C. again with the UNLV School of Public Health, and his work is on the Asian and Pacific Islander community. Thank you, Dr. C, and take it away, sir. Dr. C, you're still muted. Can you unmute?
Okay, Nicole will start the slides. Nicole? Yeah. So I'll share with you the impact of COVID-19 on Asians and Pacific Islanders, knowing that Asians is a broad category. It includes Filipino, Chinese, Japanese, Korean, Cambodian, etc. So very diverse. And then Pacific Islanders, as you can see, include Native Hawaiians, Samoans, Chamorro, people from Palau, from Micronesia, etc. So you can see, again, another very diverse group. So I think we need to really disaggregate the data so we can really differentiate the different subgroups. Next slide. So one thing that most speakers have not discussed is the impact on Asian Americans, especially discrimination and racism. As you can see, last Saturday, the president talked about Kung flu. People called some of the Chinese or Asian Americans Ebola. They talk about the Chinese virus. A lot of these very disparaging remarks. So these are very common since the COVID-19 pandemic started. Next slide. And you can see here, about 70% were verbal harassment, about 22% were shunning, or people avoid you when they meet you on the street, or some even experience physical assault or spit upon, or workplace discrimination, or they're being barred from entering certain establishment or transportation. So you can see all these different incidents that is increasing among not only Chinese, but the Asian American population. Next. So I want to talk about this, the perfect storm. You know, the perfect storm here is the cytokine storm. So you can see that it's a novel virus. That means none of us has been exposed to it. So it's a new virus infecting our population. And 80% of the people infected have very mild symptoms, or some even are asymptomatic. But 20% would experience very severe symptoms, and of them about 5% would die. And those severe symptoms is due to this perfect storm, which is called the cytokine storm. So as you can see from the diagram here, at the bottom part, you can see SARS-CoV virus 2, in contrast to the SARS coronavirus 1, which that causes SARS. The one that causes COVID-19 is called SARS coronavirus 2. And so you can see here, as the virus entered the body, this virus it triggered a very uncontrolled generalized immune response. And so this you can see the cells that are activated are macrophages in the middle, and on the right side you can see the T cells. All of these immune cells are increasing the responses, and they secrete a lot of enzyme, including cytokines and chemokines. So the cytokines, all of this would lead to, in other words, the increased immune cells try to attack the infected cells. But in the process, they also attack the uninfected cells. So all of this eventually lead to respiratory distress syndrome. So there could be respiratory failure, but also multi-organ system failure. So you can see about 20% of people would be hospitalized because they experience this cytokine storm. Next slide. And this is a recent slide from CDC showing you that hospitalization is 6 times higher, and that is 12 times higher for COVID patients with underlying conditions that the earlier speaker talked about. About 35% have cardiovascular disease, 30% have diabetes, and another 28% have chronic lung disease. All of these are the underlying conditions which are very common among our population. The health disparity population, they increase their chance of being hospitalized and also of death. Next slide. So this slide shows you by age, the hospitalization. You can see the highest rate is for people 65 and above. The next line, the purple line, is about people in the age group of 50 to 64. And then the green line is 18 to 49. So in other words, it's not just the elderly that's are hospitalized, even the other age group are hospitalized. But you can see the younger population are lower. Next slide. And then the death, usually people see, you can see the percentage, but here you can look at ratio per 100,000 population, so you can compare them. So you can see that African Americans have the highest. This one, US in national data, you can see it's higher for African American, 54.6 deaths per 100,000 population, and Latino and Asian close to each other, about 24.9 for Latino, 24.3 for Asian, and for white is about 22.7 per 100,000 population. Next slide. And this for Southern Nevada, I think it's hard to see this. I want to show you the rate on the right side. Okay, you can see here I want to show you the bottom part here, the race ethnicity. So you can see this for the hospitalization. You can see that for the Black population, you can see the ratio is 108.65 per 100,000 population. And for Asian Pacific Islander, 79.66. So it looked like it's higher for the Black compared to Asian and Hispanic. This for hospitalization in Southern Nevada. Next slide. However, for death, though, if you look at the COVID-19 death in Southern Nevada, you can see that for the highest is among Asian Pacific Islander. You can see it's 23.97 per 100,000 population, followed by Black, 23.93 per 100,000 population, and then white and lower. So for Hispanic, this is the rate per 100,000 population. Next slide. And then among Asians, it affects a lot of Filipinos. So here is an article about in times of war, the staggering toll on COVID-19 on Filipino healthcare worker, especially in, this was written in May. At that time, we can see the epicenter was in New York, New Jersey. You can see that 1 of every 4 Filipinos in New York, New Jersey area are employed in the healthcare industry. And at that time, about 30 workers have died of COVID-19. Next slide. And this is my last slide here. We're all in this together. So each one teach one. If you learn something new today, share with your family member or friends, and go to the website for prevention guidelines. Go to cdc.gov for vaccine treatment, basic science development. Go to nih.gov. For international, go to WHO website. So we must all work together to prevent, control COVID-19. And let's keep our faith very strong at this challenging time. And remember, and this too shall pass. Thank you.
Thank you, Dr. C, for that wonderful presentation. Again, all these will be on our website in case anybody would like to have access to them. Next, our next panelist is Dr. Erica Marquez from the UNLV School of Public Health. Welcome, Erica, and thank you for participating today.
All right, can you hear me and see my screen?
Yes.
Okay, great. Well, thank you guys for all those that organized this event and for allowing me to be a part of this panel discussion. I'm really excited to be here today. As I did some reflection on kind of the cultural contributions of the Latino community here in Las Vegas, I thought without question, we are part of the fabric that makes up the diverse beauty of Las Vegas. This is our comunidad, and this is where nearly 750,000 of us live, work, play, because this is what we call home. Now we find ourselves in a very distinct time in which we are pressed with trying to respond to a global pandemic, but intersected with confronting racial inequities that have impacted our communities and communities of color for a really long time. So today I'm going to talk about some of the challenges among the Latino Hispanic community. But I want to preface with saying that I am hopeful. I'm hopeful that we will make it through these challenging times. I'm hopeful that we will find solutions to some of the inequities that we continue to see persist in our communities. And this is large in part, not just to these panel of speakers that are here talking to us today, but also to the extraordinary work that you guys are doing on the ground in the community. I have, over the last several weeks, listened, talked to you, read about some of the work you guys are doing to respond, to lift up, and to take care of our community. And that provides me so much hope, even though we seem to be stuck in a little bit of a rut right now. Oh, sorry about that. So what I'm going to talk to you guys today is really briefly look at assess the impact of COVID-19 on the Latino community. And I want to expand not just into what the health impacts are going to be, but really talk about those social determinants of health. I want us to be able to link the intersectionality between these social determinants and why these are increased risk for our community and many communities of color. And I hope that we have some time to at least consider what are our next steps as we move forward. So all of you have probably seen these headlines, both on a local level, on a national level, and if you're on social media platforms, I'm sure you've probably seen it there. It's almost hard to avoid. But one of the main questions that result from many of these headlines is to understand, why is there a disproportionate impact amongst minority communities? And so what I thought today is I wanted to spend just a few seconds, I'm so sorry about that. So what I wanted to do is spend a few minutes just talking about the social economic factors that really drive health disparities. Because while COVID-19 has kind of brought this to light, We've seen it kind of in the public, in the forefront, and for the public and the media, this is really seems like new information. For those of us in public health, for those of people on the front lines, those of you who are working in the communities day to day, this is really not new information. We know that these are long-standing and persistent health disparities that are symptoms of a broader social and economic challenges that are rooted in structural and systematic barriers across sectors. And I want to repeat that one more time. They're long-standing and persistent health disparities, which are symptoms of a broader social and economic challenges that are rooted in structural and systematic barriers across all sectors. So we're not just talking about our criminal justice system, but we're talking about housing, we're talking about employment, we're talking about education. And these are really, really important to have a discussion about, and this underlying racism and discrimination that has perpetuated these outcomes in our community. We know healthcare plays a really distinct role in the overall arching of our health outcomes, right? But we know that the research tells us about these other drivers to health, these conditions in where we are born, where we grow, where we live, where we age. And they are drivers. These are our socioeconomics. These are our quality of our education, our ability to connect with our community, feel invested in those communities, or the safety of our neighborhoods and our home. These are actually really important drivers to long-term health outcomes. Now, the impact of this pandemic has mirrored and compounded these racial and ethnic disparities. So what this framework really provides us with is an opportunity to consider these factors as a catalyst for the challenging work ahead of us. How do we later then, after all these presentations are done, come together to drive change in our community? And I'll talk a little bit more about that at the end. So let's talk for a second about the determinants among the Latino community here in Clark County. Now, if we look at some of these factors, if we look at education, we are highly represented amongst the Clark County School District and even in higher education. But if we look at the outcomes to some of our communities, we have the least amount of school, kids that graduate with a high school diploma, and even less amount of people that graduate with a bachelor's degree. We can look at, we are more likely to live in poverty, to be employed at less income than our counterparts, and even to live in rental or poor housing. Now, when we look at our health rates, our health insured rates, we know that we are more likely to be uninsured. But I think the important part of the conversation in the health perspective is that we know that there are other fears and challenges affecting our community. In conversations with our community partners and with our community members, we know anecdotally there is a fear amongst our community, even if they're qualified for benefits, that if they have an undocumented member in their home, they won't apply. And this is really, really important information, because then that may delay them actually looking for services if they need them. We also know amongst our immigrant workers that we represent the essential service workers. That means that they're highly represented in their grocery stores, stocking our shelves, bagging our food. We also know that they are cleaning our hospitals. We are largely overrepresented in sectors that are suffering mass layoffs. We see this profusely amongst our casino employees and those working on the Strip. And we know that our immigrant workers tend to have lower income than those US-born peers and are more likely to lack health insurance and have a minor child at home. Now, we also know that some of our challenges are multi-generational issues. If you're anything like me, that means that we grew up in a home where it was multi-generational, where it was mom, parents, grandparents, and sometimes your tios and your tias. And how does that make it difficult to adhere to CDC recommendations? It becomes less of a reality when we have multi-generations living in our home, but also if we're also living in smaller quarters, if more of our population is living in an apartment complex, social distancing becomes even more of a challenge. So we haven't talked about the clinical risk, and I think the clinical risks are things that we've understood. We understand that these things are continued to evolve, and like some of the previous speakers have mentioned, we know there's severe illness, there's higher risk for severe illness amongst our older population, but as we analyze this data in real time, we know that this could change. This could change, that we're going to see it in our in our working class, and our ages 30 to 40-year-olds as well. And one thing that's important to understand in terms of the risk, particularly in the Latino Hispanic population, but this can cross most of our minority groups, is really the underlying conditions. Our comorbidity with other outcomes like diabetes. I think the prevalence in some diabetes populations is close to 22%, but when we look at some of those subgroups, they can be as high as 25% in the Latino community. And then compounding underlying conditions includes uncontrolled conditions. You know, who hasn't accessed care because they can't access care, they don't have a provider, or they can't afford the ongoing medication. This actually increases that risk for negative health outcomes. Now, this was produced over 10 years ago to really pinpoint the health disparities that we can actually identify in response to an influenza outbreak. And looking at how do we identify where these disparities occur. And if we look at disparities in exposure, we can think about overcrowding, whether that's overcrowding in our homes, overcrowding at medical facilities that maybe we're limited to access to, overcrowding in public transportation, or the ability to be able to work from home or not. We look at disparities in risk, so comorbidity, stress, age, smoking, nutrition, and disparities in treatment, whether we have the ability to access care or are we delaying care for some other reason, whether because we can't afford it or because there's some other concerns in accessing care. And when we look at these 3 points, we know that there is an additive effect that results in disproportionate illness and death in our community. So what is happening here locally here in Clark County with respect to the Hispanic Latino population? When we look, and this was data pulled as of June 20th, when we look at coronavirus cases, we are 35.5% of the cases amongst our minority groups. We have the highest case count. But when we look at hospital and mortality data, we're actually faring a little bit better. However, if we compare hospital and mortality data to some of the data that CDC has available, which has some limitations because we're all doing this in real time, we seem to not be doing as good as some of our national partners or across the United States. So what are some of the other additional ongoing impacts that we have to consider? And there's been some surveys just to look at, you know, what's happening in our community. 46% of Latinos indicate that they're having trouble affording food, paying for their credit card bills or healthcare expenses. 45% of Black adults and 39% of Latinos say they have skipped a meal or relied on charity since February. And so one of the things that we need to consider as the ongoing impacts is one, employment. Obviously, that's going to be a driving factor to getting our community back on our feet. We have to think about housing. There's grossly impacts that are going to happen as soon as these moratoriums are lifted. Our community is highly a rental community. What are we going to do to respond to evictions and the displacement that may occur as soon as these things are lifted? And one of the conversations that we have continued to have, or I continue to hear about too, is about our children and the education and what happens to build, to break this digital divide if we have to continue in remote learning with our children moving forward. So these were some questions. I was interested in talking to some of my colleagues over the last few weeks to find out what is our community still asking questions about. And they're still asking questions about how do you get infected? When should I go to the ER? What precautions should I take? And what resources are available? Now we're 4 to 5 months into this pandemic. And so these are still questions that are being asked by our community. And so that means we need to do better about making sure these messages are getting to the places they need to be. So what really quick is a blueprint for action? So my first suggestion here is really cross-sector collaboration. I think it'd be naive for us to think that public health, we can do this alone. We certainly can't. And we need to work across all these determinants of health, housing, employment, education, to really make sure that we all have a seat at the table and we're able to drive some of these decisions to help improve equity in our community. we need to engage in meaningful participation amongst our community about what are the needs that they have and make sure their voices are at the table. And I think some of this has already been discussed about data. How do we improve the collection and analysis of this data? And it's really challenging because we're doing things in real time, but definitely we need to make sure that not only are we taking the common race and ethnic groups, but within the Hispanic Latino community, we're a very diverse group. And so how do we understand what's happening, kind of maybe some of these subsections, or even understanding the recent immigrants versus those that have been here for some long time, because there may be difference in the response that we need to better assess. And cultural competency, making sure that our information is being delivered in a way that is meaningful and makes an impact in those communities. There is so much messaging that is going on and mismessaging that we need to make sure that our stuff is getting out to these communities, and that we are taking cultural competency in consideration, not in just our messaging, but as we respond as a community, whether that's contact tracing, testing, or any of those things to help bridge the fears and the gaps of our community. And obviously health promotion, equitable access to care, and really building our health professional workforce to increase the number of bilingual and bicultural professionals that can help aid in the response to continuing efforts to address the pandemic or other health equity issues that we continue to see. So with that, I want to say thank you for your time, and I'll turn it over to Jose.
Thank you, Dr. Marquez. Really great information to share with everybody. Up next is Dr. Crystal Lee, who will be talking about the American Indian Native American population. Take it away, Dr. Lee.
Hello, can you all hear me?
Yes, we can.
Okay, great. Hello, ya'ate everyone. She'e Crystally Inishia, Natana Eta Chitni Nishla, Nanish Eja Tambahan Bushes Chin, Sandra Kina Dashache, Kinta Chitni Dashanella. I really wanted to thank everyone for putting this together and for also inviting me to be on this panel. What I just stated to you were my 4 tribal clans in Navajo, as Jose mentioned before, that I am born and raised and an enrolled tribal member of the Navajo Nation. Are my slides up? Thank you. And so I also wanted to relay that I am an assistant professor at the University of New Mexico, College of Population Health, and have been working with tribes in the Southwest region during this time, predominantly, especially with my tribe, and in all facets you can imagine. And I'm not really going to take a scientific approach per se, but I really just wanted to give a grasp overview of why us as Native Americans, why our determinants of health are uniquely different from other racial ethnic groups within the United States. So if we can go to slide 1, please. So for those of you who are not familiar with the Navajo Nation, our tribal jurisdictional reservation land base is the largest in the United States. It's parallel to the state of West Virginia, and is in 3 states, the state of Arizona, New Mexico, and Utah. And within the 3 state jurisdictional parameters, we lie within 11 counties in all 3 states. And currently, we have the 6,963 cases were documented on Friday. Since then have risen to over 7,000 cases. And if you can look at the map of our nation on the slide, you could see that the most cases, which is currently the hotspot, is called Central in Navajo Nation. This is a more centralized place, so this means that a lot of our residents in that specific jurisdiction, where it has 1,813 cases stated, that most of our residents in that area are the least likely to have running water and electricity within that area because they're most centralized. We have about 170,000 tribal members living on our tribe, and about 1/3 out of the 170,000 people do not have running water and or electricity. And so when we're thinking about this, I'm putting myself, when I'm back at home on my res, when I go to my grandparents' house, my grandparents have no running water, electricity. So I'm thinking about the day-to-day livelihood of my community and my relatives. When I'm at my grandma's house, what we do to get water is we go to a local water well that's a shared community well, and we have to access water in that capacity. We do not know if they're being disinfected or the precautionary measures to access water from those specified community water wells. And then in addition to that, we're talking about the water not being filtered. So therefore they are not, in my opinion, they should not be consumed. A few years ago, I went back home when my little sister had a huge ceremony, and I was helping to haul water daily. And in my experiences of hauling water, when looking at the water, you could see worms and little bacteria. I mean, they're very visible. They're not minute. So you could tell the water is not good quality. And so I'm assuming there's parasitic, fungal, bacterial in the water, parasites in the water. And now if we're combining that with elders, when I was at home, I was telling my elders in Navajo, you can't drink this water. You're older and your immune system is compromised. And my grandparents will look at me and say, well, we've been drinking, this is our way of life. This is what we've been doing all this time. And it gives you an extension of not only just looking at the lack of access of water, but also the perception of utilizing the water. And then now if you acquire COVID, now you are also combining other infections or other exposures that could really adversely impact the health and well-being of our population. So within this central part of the Navajo Nation, they consist of a lot of elders within that community. And so in addition to that, can we go to the next slide, please? Now we're gonna look at a more comprehensive picture within why it gets so complex on working with tribes. And for example, my tribe is with 3 different states. So imagine working with 3 different state departments of health, working with 3 states in every level, and then also to receive the funding, because we don't get direct federal government funding, like let's say from the CDC or from FEMA. What happens is those government helping agencies is they get dispersed first to the state, and then the state reallocates that to the tribe. So when we're working with 3 different states, that makes it extremely complex with jurisdictional issues on receiving any type of funding and or aid, and also keeping up with infection rates, surveillance in real time, the reporting mechanisms from the reservation to the county to the state level. It gets truly complex, as you can imagine. So this is a huge, this is a big eye opener, I think, for people who are not really understanding about tribal jurisdictional issues. As you know, that we're sovereign nations, we have our own government systems, we have our own government leadership that we elect, and as being sovereign nations, that we work directly with the United States government and not so much with the state when it comes to more policy level interventions. So just to give you a background of what my tribe is going through when it comes to jurisdictional levels. In addition to that, as any communities of color, we have high rates of poverty, but our poverty stems from lack of our poverty rates really stem from economic development and the lack thereof. A lot of our issues with tribes are on the policy forefront. There are a lot more political issues that have a lot of red tape associated. So for instance, to open up a business in our reservation, I had a friend who's Navajo, and her father owns a construction company. To get a grocery store developed on a reservation took 12 years through all the governmental red tape, 12 years. And not only just the United States governmental red tape, but then also our tribal government red tape. So those combined, just to open up a grocery store, that's how long it took. And so the jurisdictional issues, even with the food desert, is through this. If you're thinking about the size of our state of West Virginia, the Navajo Nation only has 13 grocery stores throughout our tribe to serve that mass area. So our resources are extremely limited. And then of course, when you include the health conditions in association with that, it has been documented that Native Americans have the highest rate of type 2 diabetes in the world, especially the Pima Nation in the state of Arizona and southern Arizona. They're documented to have the highest rates. So our health conditions, we suffer a lot of disparities and from that capacity as well. And our poverty rate, the Navajo Nation is documented to have 60 to 70% of unemployment rates on our reservation. And in addition to that, just the lack of general amenities that we take for granted, like having running water and electricity here in the state of Nevada. But in addition to that, a lot of our housing, especially our elders, they still live in a dwelling that's called a hogan. And within a hogan, those are more traditional spaces, especially that our elders live in. And within a hogan, there's no separation of walls. There's no rooms. So people cannot separate to quarantine in those type of dwellings on our reservation. So now if you have multi-generational people living in one hogan especially, we don't have the amenity to quarantine them within their households alone. So that brings up a lot of issues as it pertains to housing and where to place people who get infected with COVID. And then also the lack of resources. The Indian Health Service only provides 25% of clinical staff that are needed. We're still lacking 75% of any type of clinical staff, and we just don't have the Indian Health Service dollars to truly fund our clinicians and provide more opportunities to come back and work on our reservations due to the lack of financial issues within the context of funding. And so when we're thinking about Native American tribes I really want to propose the fact that we are considered a political party within the United States. We are not considered a racial ethnic group because of our sovereign status. And with that, our healthcare system is completely different. We utilize the Indian Health Service, which is primarily on tribal reservations. And here in the state of Nevada, for example, there's only a few handful of clinics that provide ambulatory services and are not, and we do not have a full hospital. And so the closest comprehensive hospital is in Phoenix, Arizona, from here in Southern Nevada, here in Las Vegas. So I know a lot of our Native communities here, if they need to go seek more comprehensive services, they either have to drive to Phoenix, Arizona, or Parker, Arizona, which is another hospital, which is about a 5-hour drive one way. And for here in the state of Nevada, again, there's not an Indian Health Service comprehensive hospital facility. And I know that there's about 60,000 residents here in Las Vegas that are Native American, and of the 60,000 residents, majority of the residents are Navajo. So a lot of our Navajo people go back and forth between here in Las Vegas to either utilize our hospitals on our reservation, on the Navajo Nation, and or others that are off the reservation, like the Phoenix Indian Health Service or the Parker Indian Health Facility. And just to talk about the lack of health insurance that a lot of our populations do have in regards to having lack of employment, or and even just the fact that we are used to utilizing Indian Health Service as our primary mode of care. Can we also go ahead and go to the next slide, please? Just to give some additional background from a policy issue, I think that is one of the main takeaways I really want to acknowledge here when I'm talking, is that through United States treaties with the United States government, through major court cases, and through federal statutes, that a lot of the structural issues that we face in tribal communities stems from policy and law, which started back in 1823 through 1832, which were 3 key court cases called the Marshall Trilogy, which really set the primary foundation for the federal Indian policy law relationship that exists today. These 3 court cases set the tone that states do not have jurisdiction in Indian country. They state the tone that that the United States is the primary governance that oversees the tribe, parallel to a ward over a guardian. In addition to that, the United States Constitution, Article 1, Section 8, indicated that Congress shall regulate commerce with foreign nations, states, and with Indian tribes. So what this really, I guess, built was that Congress has complete power over over Native American tribes. Autonomy, they can revoke treaties, they can enact treaties. So Congress has full plenary power over United States tribes, and really this is what the true foundation is. So from a structural level, to really look at how can we support tribes, it really has to be from a policy level. And I'm going to end that. And in addition to one more thing I really wanted to state is I had started a nonprofit. I know research takes a really long time, And so if you're interested in looking at our nonprofit issues that really are boots on the ground from a grassroots level, I'll go ahead and input the website on the chat. So go ahead, thank you.
Thank you, Dr. Lee, for that information. Everybody, please go to the website and check that out. And up next, Dr. Melva Thompson-Robinson. Thank you, Dr. Thompson-Robinson, for being on this program with us today, this webinar today, and take it away.
Oops. Sorry. I was looking at my slides. So, yes, like everyone else said, thank you for having me today. Thank you all who have remained on the webinar for staying and listening. Part of me feels like we should take a potty break, but we'll push on. So with that said, a little disclaimer, some of this has been mentioned already, but just to kind of make it, to reiterate this, that, you know, as we know around COVID-19, the data is ever evolving. Every day it's changing. So what we thought we knew in April and even the beginning of May is now, in some cases, a little bit different than what's going on right now with the current pandemic. The other thing too is that in some cases, when people are gathering data around COVID-19, data regarding race and ethnicity is missing, believe it or not. So we don't know for sure race and ethnicity for everyone that is being diagnosed. And then lastly, as a disclaimer, in terms of African Americans, the way that I'm using this term here is to reflect all persons that are part of the African diaspora, but are living here in the US or in its territories, which might be a little bit different than some might consider. As our previous speakers have mentioned, the burden of death from COVID-19, what we saw in April with the COVID-19 death rates in New York City, again, higher than other racial and ethnic groups. If you're looking at whites, for example, their death rate was 42.5 per 100,000 persons. African Americans is 92.3, which is, you know, a twofold difference. So also, according to NPR, at the end of May 2020, African Americans had a death rate nearly 2 times that of what was expected based on their share of the populations. And in some states, that death rate was 3 times than what was expected. So clearly, African Americans, as has been noted, are sharing a burden of death as a result of COVID-19. So they're more likely to die from the disease once they get it. Looking here at Southern Nevada, and this is their numbers as of June 19th, and really just, you know, kind of visually for you all to look at in terms of Hispanics, African Americans, Asian and Pacific Islanders, American Indians and Alaska Natives, and whites. So again, you're seeing African Americans, their rates are, you know, 1.5 of that, 1.5 times that of whites, and Hispanics and Latinos, it's over 2 times that of whites. And this data came from the Southern Nevada Health District. So what I don't want to do a big deep dive into the data because again, a lot of our speakers have already talked about that. So want to move into this whole question of why. And I think a lot of people have already tried to talk about this from, you know, their particular population, but why in particular for the African Americans? So one of the first things that we'll talk about is health status. And so, as has been mentioned before, African Americans have higher rates of comorbidity. So they're more likely to have hypertension, diabetes, other immune disorders, lung diseases, including cancer. And those, as we have seen from the information from CDC, put people at higher risk, not only for contracting COVID, but also having poorer outcomes. And another challenge with African Americans as it relates to these, and I'll talk about this a little bit more in a second, is oftentimes African Americans will have some of these conditions, particularly like hypertension and diabetes, and not always be aware that they have, or they've never been formally diagnosed that they have these conditions. And so, you know, your first time finding out that you have diabetes and you have hypertension should not be at the same time when you're also finding out that you have COVID-19. So, you know, an area for work. Another issue that affects the health status of African Americans is this historic distrust of medical providers and the medical system. Part of this comes from the Tuskegee syphilis study, in which during the Tuskegee syphilis study, African American men who were already infected with syphilis were followed by the U.S. Public Health Service to determine what the disease course was as it relates to the progression of syphilis with someone who's infected. And so, you know, that has a historic impact. I just saw somebody post a picture of a doctor, I think it's Marion Sims, but I know it's Dr. Sims out of South Carolina, who has been credited with the start of modern gynecology. But what people forget is the surgeries that he did were done on African American women who were slaves, who were not giving any kind of anesthesia because they were thought to have high pain tolerances. And in some cases, they were just brutally brutally cut apart as a part of all of this. And this is not, you know, like some of you will say, well, you know, Dr. TR, that was, you know, slavery was, you know, over 150 years ago, that the Tuskegee syphilis study, although it was stopped in the early 70s, you know, the apology wasn't given until I believe in the 80s, late 80s, early 90s. Like that, how does that really impact us? But the challenge is those are like the big things. I shouldn't say nobody, but people don't really see the day-to-day things that go on when people go in for a health services. So for example, my mother, who's actually on this call, one of the things that she talks about when she comes to my class, having grown up in educated segregated South Carolina, is the fact that African Americans were seen last after all the white patients were seen. So it didn't matter what you had, you were just seen last. You weren't seen in order of your appointment or in order of what was going on. So this historic mistrust is something that's very real for a lot of African Americans. The other thing is, and I kind of have alluded to this, is in general, African Americans then receive care late. So we're going to the doctors late and we're finding out things late, which then results in later diagnosis or a later stage diagnosis, which often means now we are sicker when we finally do get diagnosed, which now creates an opportunity for us not to have good outcomes because it's almost too late to do anything. And we're seeing some of this now with COVID-19, whether it is people being hesitant to go to the doctors or to go get tested, or we're seeing the flip side of it as well, is where people are going in and they're being turned away by our healthcare system and being sent home only for when they finally do get seen. And in some cases, it's been documented like 3 or 4 trips to the healthcare system that they're finally being seen, they're being diagnosed with COVID, but they're in such a late stage that there's really not much that can be done. So when we're talking about health status, these are some of the things that we're talking about. Now, some of the previous speakers have talked about social determinants of health. And so according to the World Health Organization, the social determinants of health are the conditions in which people are born, grow, live, work, and age. So basically it's kind of everything around, what it is that we do. And when we're looking at COVID-19, there are some social determinants of health that play a significant role here. So the first one is employment status. So African Americans, like Hispanic and Latinos, are more likely to be deemed as essential workers. And not only that, they're also more likely not to have paid sick leave. And so how does that factor in? It's if you can't afford to take time off from work because you're not getting paid, you're going to go to work regardless of whether or not you have symptoms. And you may say, oh, well, it's just allergies or it's just this. And in the meantime, you're infecting everyone around you. So having that paid sick leave, having those employment opportunities where you do have paid sick leave is essential. As was mentioned with the Hispanic and Latino population, the multi-generational housing is an issue. So for some families, the isolation of a family member or quarantining of a family member within a house may not be possible, okay? Because there's too many people in the house is not big enough. And some of us can think, some of us are in situations where our family's already getting on our nerves. So now imagine being in a multi-generational house where people don't have room to move around and to isolate or to get a breather or let their hair down at some point. So these social determinants of health are really important. But one thing that I want to talk about and I want to mention is one of the things that we're not always talking about in public health, but we really honestly need to have some serious conversation about. And that is racism and the impact of racism on public health, what we're seeing now in COVID, what we're seeing even now in terms of people taking to the streets and protesting in a global pandemic because things are so bad in their communities, okay? And so, a lot of times what we're talking about, racism becomes this underlying current that crosses over the social determinants of health, it crosses over everything. Now, what we're talking about when we're talking about racism isn't necessarily, visions that people have of the Klan showing up and burning crosses. Yes, that's, white supremacy, and that is an issue. We're also not talking about people necessarily being called an N-word to their face, okay? But we're talking more about the structural racism. What are the systems that are already in place that are giving some groups of people an advantage that other people don't have or haven't had? So, we know that our first Africans came to the US just over 400 years ago, okay? And we know that slavery went until 1863, 1865, depending upon where you were in the country. And then came around Jim Crow, which lasted into the early 70s, okay? So it's really been since the late 60s, early 70s that African Americans have started to have some of the opportunities that other populations in this country have had for centuries, okay? So already African Americans are starting out somewhat at a disadvantage, and it's seen in the structures that we have. So we know, and as I've said, employment oftentimes is based on your educational level, okay? But your educational level is based on where you live. redlining by financial institutions, which occurred into the 80s, dictated where you lived. Okay, redlining was the practice by financial institutions by which they either approved or did not approve loans for housing based on your race. So if you were, for example, African American and attempting to buy into a predominantly white neighborhood or into the suburbs, there's a very good possibility you were not going to be approved. So you were going to be relegated, for example, as we've seen here, or what has happened here in Las Vegas, into the historic West Side. Okay, well, we know that the historic West Side, the schools tend to be poor, there is no grocery store, there's high crime rates, and so on and so forth. All of this is a structural racism system that has created almost a perfect storm for people now, because now, you know, it's easy to say, oh, well, you should have gotten your education. But if your schools aren't at the same quality as the schools in the suburbs, you're already at a disadvantage. And then again, we've said your educational level relates to what it is that you can do employment-wise, then now you're at a greater disadvantage. So this structural piece is really important. And I think it's important that we start looking at what are these systems that are in place that have not historically treated people fairly, and how do we go about treating people fairly? So in conclusion, and you know, obviously I could talk about some of this for hours, and we don't have that. So let me just kind of give you some things to think about. So addressing the COVID-19 and its aftermath, because you know, as some people are starting to go back to work now in the state of Nevada, there are quite a few people, including the African American community, for which the unemployment rate has actually increased and not decreased, okay? So again, addressing COVID-19 and its aftermath in the African American community is not going to be a simple fix. It's not going to be as simple as, oh, well, you can go back to work, okay? Traditionally, African Americans have been the last hired and the first fired. And so you don't have the seniority on the list to be able to be called back right away. We also need to start examining the intersection of the data. So, you know, we've presented data around, you know, African Americans or the Latinx population or Asian and Pacific Islanders. But we really need to start looking at what's going on with African American women? What's going on with African American men? How does this fit in terms of age or education or comorbidity situations? Having health education, so teaching everybody to wash their hands and getting everybody to wear a mask and, you know, all of those prevention methods, and a vaccine may not be enough because of the historical trauma that people have had over the years as a result of, you know, the Tuskegee study and other studies and other things that have been done. The African American community may be one of the ones that's slower on the uptake of the vaccine. And then lastly, our strategies are going to have to be more comprehensive and holistic. So it's not going to be, oh, we'll just get a vaccine. It's great if you get a vaccine, but if you don't have a job, then it's kind of like, well, why am I getting the vaccine? So we've got to think about more holistic things and looking at some of these social determinants of health and figuring out how do we address these while at the same time addressing COVID-19 so that people will start, African Americans in particular, will start to be healthy and their community will start to recover from all of this. So Jose, that's enough for right now. And we can revisit questions shortly.
Thank you, Dr. TR. As always, great information and multiple things that we all need to be thinking about. So this brings us to our last panelist, Dr. Lauren Chappell-Love. If you're ready, please take it away.
Copy that. Is everybody able to hear me?
Yes.
Awesome sauce. So I am, in fact, Dr. Chappell-Love. I wanted to talk within my wheelhouse today. I'm surrounded by amazing medical experts, and I find myself being how I usually describe as like a neck up doctor. So in the same notes that you've heard a lot of folks today talking about the medical implications, I wanted to speak a bit about the psychological impact of COVID-19. Certainly there's a ton of intersectionality, as Dr. TR and other doctors got into, but specifically on LGBTQ and 2S or two-spirit populations. So let's jump into that. The psychological impact of pandemics and illness outbreaks at the individual level, I think is the place that I, of course, started. I tend to work with people on the individual level as a psych assistant, which is Nevada's fancy way of saying that I'm basically in my residency or my last year of supervision prior to also being able to call myself a psychologist. But when we take a look at on the individual level, how people are being impacted, you start to really be able to gauge this by taking a look at the supports that folks usually have in their lives. This can be schools, friend groups, activities, sports clubs, different hangouts and meetups for young adults, social arenas, bars, clubs, coffee shops, the list goes on. So now let's take a look at the type of social support in the past 3 months when a large number of those things that I just mentioned tend to be shut down, or perhaps there is a certain increased amount of risk in trying to go to some of these places. There has been a number of different research studies done on the different types of impact. I think we as a field in general are putting out, I don't know, somewhere around 40 or certainly more than 20 like a day. So this is effectively, as I try to explain to folks, we're building the airplane as we are currently flying it. But one of the things from the various 2020 studies that I am going to be calling upon here is at the individual level, we can really start to see how new psychiatric symptoms are precipitated in folks without mental illness. So that's alarming. On the other hand, extant mental illness symptoms are in a lot of cases aggravated. So aggravating conditions of depressive disorders, anxiety disorders et al. And this is, of course, regardless of exposure. I think people are being hit by this particular pandemic and what might in some cases lead into an epidemic on multiple levels. So there might be a anxiety regarding, am I going to be exposed? Am I going to fall sick? Am I going to die? What does that look like? Helplessness, blame, other common social determinants and psychological symptoms are going to be there for some folks. As for folks who are sick or quarantined, they might also experience shame, guilt, stigma. Down here in Vegas, I was reading an article yesterday that around 5 different restaurants have been shut down based off of our very recent reopening of phase 2. And so those who are grieving traumatic losses, those who are seeing losses, seeing those numbers skyrocket in our particular state, all of these, of course, lead to anger, resentment, other types of psychological and diagnostic criterion, and of course the symptoms therein. So if we continue through our slides and take a look at the psychological impact of pandemics and illness outbreaks at the community level. Now this, of course, offers some of the pieces that my fellow presenters were speaking about. So we're looking at financial losses, risk of unemployment, housing instability, increased unemployment concerns, having less money, having less opportunity to pay my bills, keep my family safe, which of course, I also tend to use some money to facilitate socialization in a healthy way. If I can't go out, perhaps I have a PS4 that I play with my friends on, or I'm using internet services, things along those lines. I would be, of course, remiss to fail to include that though there are a number of different intersectionalities with Black and African American communities as well in this vein, LGBTQ populations also share a distrust of medical field and testing. I take a look at the AIDS and HIV pandemic at the time, epidemic now, but the almost what felt like a plague upon our people in the mid-late 80s, early 90s, still going on today. There is a certain amount of distrust from the system, if you will, from having a president back in the day that didn't even want to say the word AIDS, to when we as a community kind of collectively had that Rock Hudson moment where it's like, so other people are able to get this as well. And then it became a thing where task force were created and things along those lines. I'm of course remiss at the general lack of data on sexual populations, on gender presentation populations, on sexual orientation, and have had some difficulty relating that specifically to COVID-19 data. But what we can say is that there is a certain amount of increase in the risk for a number of mental health concerns just simply within LGBTQ populations. So I also want to focus on the psychological impact of international levels of communities. And so as we continue forward through the next slides, we're taking a look at xenophobia, racial targeting, increased bigotry, blaming, and all of these different things just basically fueling further unrest, right? As we take a look at the emotions that of course come from exposure to all of these components I just brought up, emotions can also be amplified by those pre-existing mental health disorders, oftentimes in particular your mood disorders, right? So bipolar, depression, anxiety, also taking a look at trauma responses. And so a person might, their world might start to feel as if it's getting smaller. I really can't leave my house. I don't really hang out with too many people anymore. Perhaps I'm living in a home where, I'm not being supported, or at the very outset, I'm being harmed in some way. All of these negatively impact. And I thought it was so important, this next statement, that I put it on a slide all by itself, that LGBTQ youth tend to be at an increased risk for a number of mental health concerns. Now take that, which was a prior to the pandemic statement, and then take a look at how our youth are being impacted in an exponentially higher degree during this current pandemic and moving forward. I want to focus here on the youth. So taking a look at folks that are under 18, to say nothing of exposure to COVID, now people are being exposed to more pronounced risks, in particular transgender youth, non-binary youth, folks that fall into several of those categories. So when we're looking at vulnerabilities to negative mental health impacts, this is exactly why we needed to have these conversations. The Trevor Project did a study as we move forward to the potential impact of physical and social distancing on LGBT youth. And this study was the implications of COVID-19 for LGBTQ youth, mental health, and suicide prevention. So this came out fairly recently in about April of 2020. And it really got into how are we seeing youth in particular within our community impacted in a psychological manner. So point one, of course, was that decrease in positive social interactions. I'm not able to go out to school to hang out with the clubs or my other friends or things like that. I'm not able to go out to a local watering hole if you're over 21, or to go out to hang out at a place, even a bookstore, to discuss different things. So of course, Green Dorison and Price Feeney in 2020 talked about the unintended consequence of physical distancing as potential loss of social connections, which oftentimes offer a certain amount of protection to LGBTQ youth from suicidality in particular, but also from other mental health concerns and social determinants. So when we're taking a look at the risk for suicidality, this also becomes exacerbated, in particular when we see the increase in negative social interactions. So again, if I'm having to physically distance in order to keep myself medically safe, I might have now been confined to an environment or to a home that may, of course, be unsupportive or abusive, which is oftentimes one of the reasons, we in the community tend to seek out positive social interactions. Moving forward to the next slide, I wanted to end, as so many of us did, on a bit of a high note. So how can we minimize these risks? If you are a absolute nerd like me, the first thing I think of is research. How can we, identify what people are doing, what is working well, what is not working so well, and how can we start to tease these things apart? So to start in that vein, although hopefully not in perhaps a boring manner, certainly that Trevor Project study talked about addressing the potential negative social impacts of physical distancing. And I've been working lately at being more purposeful with my words. I say physical distancing as a reminder to everybody, even folks that don't identify as part of the family or part of this community, that we are not necessarily talking about social distancing. Across the board, we're seeing mental health experts, myself included, talk about being able to remain within social relationships. That's a basic right that we know, a thing that we know in the field, that being able to have positive social interactions typically helps people across the board. This is compounded yet again, in particular with LGBTQ communities, in that if I'm in a home and I have a non-supportive parent or other individual that lives in the home, that negatively impacts me. Typically, we see that larger impact for youth. So how can we help? We can try and reach out to folks. It's important to know that even with physical distancing, it does not equate to social isolation. What we're trying to do is prevent isolation. We know that requiring solitude can be a component of self-care. I know I have also sought solitude in these recent months. It gets tiring to have the conversations, to have the arguments with the people online, things like that. So solitude is very, very different from isolation, and really helping our youth understand that, as well as our community as a whole. There is a thriving, I would say, online LGBTQ community. These are oftentimes opportunities for people to talk about television shows or movies or other interesting things like that, and also just to kind of link up with people that I think are like me. That in and of itself can really help to minimize a risk for increased psychological symptoms and concerns there. Another would be to maintain existing connections through virtual means. Now, this is perhaps the ways that all of us have been getting creative lately. I know I'm currently regretting not having taken more information technology courses when I was back in school. But aside from the Zoom fatigue that perhaps a lot of folks are experiencing, engaging in video calls, video conferencing, online gaming, watch parties, physical activity classes. I can do yoga with my friends online. All of these things are ways to minimize risk, even if I have to stay within my home. I've seen people also engage in things like outside activities, of course, utilizing CDC's and WHO's best suggestions for distancing and safety measures there. Those in positions to support or serve as role models for our LGBTQ youth. We're talking about organizations, media, adults in general. We get to, of course, encourage people to make and to maintain social connections, and that helping them see that that is a portion of practicing self-care. Additionally, for the school professionals that might be in the audience, as schools start to move their academic curriculum to online delivery or perhaps a partial, we have to ensure that schools are also protecting the factors that support our LGBTQ youth, such as like extracurricular activities that can be accessed virtually, things along those lines. And so we know that all of these activities and the support and getting out there and letting people know that you're not alone, giving resource numbers if people are experiencing acute stress symptoms related to COVID, related to isolation, related to being in a home that perhaps isn't supportive for them. Resources. One of my slides here as we move forward includes some resources from the National Suicide Prevention Lifeline, CDC, Trevor Project, as well as a number of other different ways for people to chat, to phone in, to text. I, of course, am an old fuddy-duddy at this point, and so I am always ever aware of trying to be in tune with how young folks are reaching out, which, of course, might include Snap and just other things, other social media platforms along those lines. So I try to remind people too that there is a variety of ways that you can reach out or that people can reach into you if you, of course, are needing help. I've also included on my final slide here some references if, of course, you are a research nerd in the same way I am. And in closing, I just wanted to thank everyone for the opportunity to talk about this topic. I think that again, the intersectionality right now of dealing with the different social determinants that are going on and the underemployment or the non-existent employment, the unstable housing and things along those lines that we can really start to see. In particular, I think that Black and African American trans communities really need our support, our vocality right now, and our help, as there is in some ways a triple pandemic going on for folks within that community. So I appreciate your time. Hopefully it has not been too much of a boring research hour, and please let me know if there's any other questions.
Thank you, Dr. Chapelove. And so with that being said, thank you to all the panelists. I know we are way over time. Thank you to all the participants who joined us today. I did, in the chat box, I did put my email, direct email, and also the email of the coalition. If folks can, if you have any specific questions or information, other things that you want to share with this network of folks, please send it via email. We will work on putting together a summary from today's information, and also the information that was presented will be on our website so that folks can get to it. Again, thank you to all the panelists. Thank you to our hosts, co-host organizations for this program. Some key points that were made out that I just wanted to stress, that I took some notes on. Again, the critical need for information and communications amongst our networks. Understanding the data needs to be disaggregated to a much more in-depth level. As several of our panelists pointed out, racism and discrimination is well into live. And we need to do all we can to work together to address that. Cultural competency in this work is critical. It's not enough to put information out there. We know that there are language barriers. We know that there are age barriers, levels of education, all the different technology access. We know there's a lot of challenges to getting the information out to these communities. Dr. Lee, with her point on infrastructure or lack of in various communities, not only the Native American population, but other areas. So we all need to be working together to address this. And again, I want to clarify, this is only the beginning in this series. We will be, in the next couple of weeks and months, we will be going more in depth with each of the populations and other identity populations so that you can have more detailed information and insight to each of these populations or populations that you feel need to be addressed. Again, I would ask you to email us. Let us know, beyond the ones that were presented here today, if there's other populations you want us to look at, that we can work with you to develop this video documentary of the impact of COVID-19 on all of these cultural identity populations. So again, on behalf of the coalition, the UNLV School of Public Health, and all of our other sponsors, I want to thank everybody, our panelists, our other moderators, and our attendees for being involved. Stay safe, be healthy, and we look forward to an ongoing conversation in this process. Thank you, everybody, and signing off. Adios.